this looks okay, then I'm gonna move it back.
Done.
I didn't touch it. It moved.
That was me.
Okay.
Here we go.
The broadcast is now starting. All attendees are in listen-only mode.
All right. Welcome. Hi, everybody. Hello, Alicia and Jennifer, and all the CCO team in the background.
Good evening.
Wax on, wax off. How's everybody doing tonight? Let us know in the chat if you can see and hear us. As it says on the screen, number one, if you can see us and hear us. And if you cannot, let us know or log back out and back in. So an interesting day in our world, isn't it, ladies?
It's exciting if you're in the medical field.
Yeah.
Alicia was working on her hair, so let's acknowledge Alicia's hair, which she did a great job on today.
Yes.
How beautiful it is. Yeah.
You guys are Boyd's first thing. Does she have her hair up in rollers again? I haven't done that to him in a while.
She'll just take them out and it will just be gorgeous. And it was. She just unrolled them and there's all these little locks and curls.
Let's acknowledge you guys that besides the many changing hair events that I have, but I put a color rinse in my hair. So can you tell it's darker? Yeah.
Yeah. So of course we're going to probably have a serious kind of webinar tonight, but during these breaks between, we're going to try to keep it light. So let's not all get all too serious. I know that I'm getting out of control with my family sometimes. So go ahead.
Who knew that toilet paper was a cure for coronavirus? I mean, who knew? Yeah, I was going to say, I thought that maybe we should go out and we should frustrate some people and see if they'll TP our house. But
okay, I'm going to read the slides now and get us started. So,
okay.
Welcome to the Certification Coaching March 2020 Q&A webinar. We're going to be doing a special webinar tonight about the COVID-19 and coronavirus and all those things associated with coding that we've had time to prepare. It's a ever-changing topic right now, and stats are always changing. Answers are always changing, but we're going to do the best to answer those as much as we can. So if this is your first time to the CCO community, we want to let you know that we really appreciate you taking time out of your day, first of all, to be with us. And we're going to be talking about all things medical business certification, medical coding, billing, and practice management related. And again, with a special kind of focus tonight on COVID-19. So we want to know, first of all, if this is your first webinar or not. So please let us know by answering this poll that I'm going to get started. And Alicia, you can take over and just ask anybody what they want to talk about here for a second.
Because we know I've got one eye over here and I can see some of the people coming in that I recognize. Of course, Whitney, one of our frequent flyers. How many CCO webinars have you attended? Is your first time? Back for more, repeat offender, liking it here at CCO, or CCO frequent flyer. We enjoy our frequent flyers. It makes us happy to see those names we recognize coming through. So let us know which one you are. And if this is your first time, thank you for joining us. Tell us in the chat how you found out about us and why you decided to join us tonight. That'll help us in our marketing because, as you guys know, our frequent flyers know, we don't really advertise. So we appreciate you coming. And let's see, what do we got? First time, 43%. Wow. That's a record. Oh, wow. We've never had more first timers. So yeah, let us know. Julie said a coworker sent this to me. Excellent. You know what? We appreciate that because you know how you see all those YouTubers like and subscribe. Well, when you share
LinkedIn,
the information
Facebook.
That we give you,
wow.
LinkedIn, yeah, they allow us to do these free presentations for you because you're helping us with our advertisement, and word of mouth really carries farther than us doing ads. So thank you very much, guys. We hope that you're going to benefit from tonight.
Thank you so much. That is very true. And I'm not sure why it's still showing my Why it's showing my thing?
Well, that's
So we
interesting.
have
Somebody
something going
said
on
a
little
lot of
different.
people are sharing on Facebook today, so that's really nice.
Yes. It's better to share content that's going to be valuable to you at work, or even if I know that I invited some people from back home. I said, hey, you guys want to see what I do for a living? You don't have anything else tonight? Join our webinar. Now you can see what we do over at CCO. Noelle said, I found out about the webinar and the AAPC officer board. Great. You know what? A lot of local chapters are canceling, and you hear us at the end. Jennifer and I will go to your local chapters and offer, to come and speak. She's over on the northern East Coast, and I'm in Texas, and I had a bunch of stuff set up, and they've canceled. But I can turn around and say, hey, you know what, you guys, we offer remote. We're used to virtual, so let us offer that to you. And sure enough, that's what they're switching to. So, and the AAPC, this last year started saying, we're going to allow virtual meetings. So that kind of fills into what we've been doing for a decade anyway, right? Right up
They
our
allow
alley.
2 a year, and you can use either a virtual meeting or a virtual speaker. So either way, either format is acceptable. You can have somebody logging into your meeting that you're holding, although nobody's really holding a meeting right now. I mean, in my state, we can't have gatherings over 10 people currently. So there goes all of our meetings. But
if you have a virtual
you can have
meeting,
a virtual meeting where all of your chapter members can all see the same content then. So that's nice to be able to do that, especially trying to get, if you're in like Minnesota during wintertime, or if you're, things like summertime, everybody's so busy with kids soccer and events that it's sometimes difficult to get people together all in one spot.
Yeah. Boyd's got us. So we're doing something a little bit, well, we've done this before, but Boyd, I'm not running the computer. We're using Boyd's new computer, in another
not
state.
Anymore. I'm trying to get other things working here, and it doesn't want to do it. So you may need to bring up the slide deck, Alicia.
Okay. So while he's doing that, I can go get that.
Sorry,
what's
guys.
really cool is
just let me explain just for a second. Something with the poll just kind of messed up everything for the first time. So we'll figure this out. But Alicia, pull up your slide deck while I see if I can get this figured out.
Don't worry, Boyd. Barb still loves you. You rock.
There you go.
Yeah, I saw Barb and Boyd go way back, don't you?
Change presenter. Jennifer, just don't share your screen. I'm going to switch it over to you and see if we can clear this up for a second.
Okay.
This will be a nice.
So don't hit show my screen. Okay.
Actually, do you have the slide deck ability to grab it?
I don't. I can grab it.
Maybe grab it. Just maybe this will clear itself out because mine may need.
I was going to say because mine, I closed mine out and it'll be slow.
Let me see if
going
I can grab
back,
it.
well, we've been doing this a decade, guys, and I can multitask and tell you about us doing that. We've morphed through a lot of different changes through the years, but one thing that we are very good at is doing remote presentations, and that's because we're a great team, and we've got our behind the scenes guys. We've Boyd runs all of the webinars and IT stuff, and then he is the one that gets everything set up so that we can chunk that up and put that out on YouTube and Facebook. Now we live stream on YouTube, Facebook, and LinkedIn, because LinkedIn, good for them. This last year, they opened up the ability to live stream. And so it was kind of hot there for a little while. Everybody was doing it, and then they kind of dropped off. But
I don't think I have the slide
not
deck.
us, because we can do it. Let us know, too, if you like to watch our YouTube videos, or if you're watching us on LinkedIn. I'd appreciate knowing that in the chat.
Very strange.
I don't have the slide deck.
But I got it here in just a minute, but it's going to be slow coming up. And if you want to leave that screen up there for a little bit, we can talk about that.
Which screen do you see?
I see
what are the
what
introduction
you see
and
the
the
agenda now?
Q&As. Yep.
Okay, great.
Yep.
Let's just hope that the recording goes well.
So-
Okay, that's all I can say. Great. So let's get on to the agenda. Jennifer, what are you talking about tonight?
Well, I have 3 topics, and actually, they're all on COVID. So I'm going to talk about what Medicare has to say about COVID, because I love billing, so I'm going to talk from the billing aspect a little bit. The commercial insurances, those are different than Medicare. So what do they say about COVID and how you can bill? And then we have a question, what about if a person is seen in the office or the clinic and has to go to the ER because of coronavirus or COVID? How do we handle that situation?
And Alicia.
And surprisingly, I'm going to talk about COVID too, the COVID virus. So, and as you know, yes, Jennifer is our billing expert, but I really like the disease process, right? And the ICD aspect of it. So that's what I went with. And I want you guys too to know that this is all questions that came in. You guys have been hitting us hot and heavy with those topic requests. We appreciate that. So it's not like we just came up with this. You guys were asking these questions. And the first one is virus, signs and symptoms of the coronavirus. When you're coding, we need to know the signs and symptoms. Then safety in the workplace with coronavirus, got a great resource for you. And then medical coding for coronavirus. And this isn't the particular order we're going to do them in. However, stay till the end. Don't forget, we do give away some great stuff at the end. And Boyd went in and put these topics in a specific order for us. So we're excited. That giveaway, you can either have a Blitz video package, you can have a 1-hour phone call with us, or you can have a 1 year of the CCO club, which really is awesome. Our CCO club, the COVID virus, everybody's talking about it in the club. We have a brand new platform, so easy to navigate. And so if you guys are already in the CCO club and you're using the new platform that we launched here recently, let us know in the chat. Okay. Someone asked, where's the chat? Well, you're in the chat. The thing of it is you cannot see other people's comments unless we respond. Okay. We're seeing your comments and we do see them all. We have several behind the scenes people looking. We've got Jesus and Lori, and I don't know if Sylvia is there tonight or not. Stay till the end. We're going to be doing a random drawing, and one of you lucky winners are going to get to pick from these 3 things. Now let's see if I can drive.
Nope. But
I can't drive. Okay.
I can move the slide for you, and I will fix that here in a second once I figure out where I am. Okay, great. So we're going to talk about the club just real quick. We'll actually, we'll talk about this later because I know we're a little bit behind. Yeah. And we're going to skip this poll, and we're going to skip the graduates, maybe come back to that, okay? Because I want to get on to the questions and respect everybody's time. So this is our prepared questions, basically, that started us off here tonight. And I believe we've got Alicia starting with our first one.
And it's a lot of fun. So the question that came in, the medical coding aspect, how do I code all of this that's happening? It says, has a specific diagnosis code been created for the COVID-19? If a pediatric child comes in with bronchitis and is diagnosed with bronchiolitis and coronavirus, and this is N163, that's not the one that we've got going on now. What should we code? What should the code be? Exciting news happening, guys. Really, really amazing. We'll have to make that big, Boyd, fill the screen, or I won't be able to see it. I'll have to get my readers out, and my readers are not going to match my lovely blouse. Let's step forward. Okay, so several questions came in regarding that, so I kind of clumped them all together. And one of the questions was, the current CDC coding advice states that first the disease process and use additional code for the COVID virus, and they mentioned B97.29, and said, how would you report that when the patient is detected to be positive, but they are asymptomatic then how do we, is that going to make a difference? What if a patient gets discharged to home and remains asymptomatic, but the patient was kept in isolation in the hospital just for quarantine only, right? So this came in actually from the United Arab Emirates. We know this is a global pandemic, which doesn't mean, pandemic doesn't mean how severe this is. It means that it's hit every continent, that it's global. That's really what a pandemic means. And so the United Arab Emirates, they use the code set that we do, and they're associated with us. So first thing, the Centers of Disease Control and Prevention, that's the CDC. Everything that I obtained that you're going to see on this slide is going to be from the CDC or WHO, the World Health Organization. And there are a lot of links for you to be able to follow up. Usually I just do footnotes, but unless you're in our club, you won't have access to follow up on these answer sheets that we call them answer sheets. So I went ahead and did a reference page for quick reference for you guys. Guess what? The CDC and WHO did something unprecedented. What they did was they broke down a timeline and they actually created a code for the COVID-19. First thing, March 18th, 2020, the timeline started. And they're saying that it was declared a pandemic, meaning it touched globally. There was an outbreak globally. So on that happened on the 13th. Then the 18th, they got together and they stated, hey, we are going to, again, do something unprecedented. We are going to go ahead and create an ICD code for the COVID-19. They don't do that because it's against HIPAA. Now, again, when we say HIPAA, most people, the first thing they think in their head is privacy, but HIPAA is much broader. It's bigger than just privacy. It actually is a cycle of the codes that we use, and we know they go out like October 1st of 2020. And they said April 1st, that's just in a couple weeks, the new code for the COVID-19 is going to be U07.1. That's a very unusual code. Now, I'm going to backtrack just for a second. What do you always hear me say? I mean, I say this till I'm blue in the face. We code for statistical purposes. It just happens to be a convenient way to get paid. The CDC and WHO doesn't care how we get paid. No, they want to track this for statistical purposes. That's why a code has to be implemented now, not as the new code set comes out, we'll have it. And we have codes for coronavirus. There's several. There's SARS, there's MERS and stuff. That they are coronaviruses. And we have the coronavirus code for other, meaning there's not a code for it yet. However, this is so important that we track it in that it's a pandemic. They've created a code now. It's going to be implemented for us at U07.1. So until April 1st, what are we going to do? First thing you need to know is do not, and I mean not in red letters, use B3 4.2. Now, we would think that would be the coronavirus code that we use, and it is a coronavirus code. Okay? However, it's unspecified. And even though the code hasn't started, the U code, this is specified because COVID-19, which is the name that it was given by WHO and the CDC, or who does it. They officially named it COVID-19. This is specified because it's a respiratory coronavirus. Now, other coronaviruses work at different parts of the body. We have to remember, this is the flu. It's just the flu, a viral flu. However, it's a viral flu in the family that affects the respiratory system. So it is not unspecified, it's specified. So we need to let our providers know that B3 4.2 is not going to be the appropriate code for COVID-19. In fact, the correct code until our new code is implemented is B97.29. This is other, because other is specified. All right, so we're getting going back to that basic coding knowledge. In the meantime, signs and symptoms. We need to code the signs and symptoms if we do not have an official code diagnosis. So we would code R05 for a cough, for shortness of breath, the R06.02, and the fever unspecified R50.9. Now, I know what you're thinking. You're saying, well, wouldn't we know right away? Yes, you would. We can test for the virus to see if somebody is positive or negative, and they can be asymptomatic. However, what if there's a shortage like there was temporarily for that test? So you go in with flu symptoms and you have the cough, the shortness of breath, and the fever, which are this COVID-19 signs and symptoms. So you got the flu, right? But it represents or it shows itself with these signs and symptoms. You're not going to have nausea and vomiting and so on and so forth. Next, what do we do then if we are going to code signs and symptoms, but the doctor suspects, or they use those words like possible or probable COVID-19, because they will probably do that? Documentation does not implement us or suggest that we use B97.29. No, okay, because that means they have it. They have confirmation. So what do? We do the signs and symptoms, the R codes, and we code Z20.828, okay, that the patient has been exposed to the virus. Now, I also want to bring up some Hickspicks codes that have been created. The U0001, if you're going to do CDC testing laboratory. Now, this isn't just going to the lab. This isn't a Quest or anything like that, or the lab there that you're using in your facility. This is a CDC testing laboratory for COVID-19. You have a Hickspicks code of U0001, but if it's laboratories that's non-CDC, you're going to be using U0002. Now, this is only for the COVID-19. Very good. All right. Now, went ahead and put in kind of smaller letters, Medicare, and I'm sure that this is going to be highlighted by Jennifer because this is her realm. Just so you know, we have to track that. That's why we're given specific Hickspicks codes to use. We want to know how many people got sent to the CDC laboratories, how many of these tests were non-CDC, and how many people were exposed, how many people were just have the signs and symptoms. So now let's talk about the scenarios and the ICD-10 codes. Made a little table here for you. And again, this is what you're going to want to go back to your office with. We will create a great, I guess another name would be a cheat sheet for you to be able to take to your providers or use at work. And if you're in our club, you'll be able to access this, of course, but this is the pertinent information. These are the scenarios that the CDC came out with. And then I pulled them directly from, like I said, the CDC for our guidelines based on them. So a person comes in with pneumonia due to COVID-19. How are we going to code that? This is just straight up pneumonia. Then the proper ICD code is going to be J12.89, and then our COVID-19 code B97.29. Pay attention here. Every single one of these are, all except for the last two, they are due to COVID-19. Now, if a person comes in with pneumonia and they don't test positive for COVID-19, then you're not going to use the B97.29. Okay. If they come in with pneumonia and actual exposure, but they don't test positive, then you can use that Z code. So acute bronchitis due to COVID-19 is going to be J20.8, and then your COVID code. Then acute lower respiratory infection or not otherwise specified. Right. So now again, pay attention to the wording because this is going to be critical so that we can statistically capture this. We don't care about getting paid. We have to capture this statistically so that we can get a vaccine and we can also get proper treatment and how to, this is all based on what we learned about SARS and MERS in the background. So acute lower respiratory infection or NOS, then it's J22 in our COVID code. Associated lower respiratory infection, NOS, and COVID. That's supposed to be COVID-19, not COVID-10. I see that now. I don't know. I must have fat fingered that with the pinky there. So J98.8. So what's the difference in acute lower respiratory infection and associated lower respiratory infection? Make sure that your providers are being, distinguishing the two. Acute is your key word there, right? And then ultimately, with people that have comorbidities, it's a very, the people that are passing because of this, they ultimately, are getting ARDS, right? So ARDS due to COVID-19 is going to be J80B97.29. So ARDS, that's when the lungs are shutting down, acute respiratory distress syndrome. Now, that's our J codes. We know they're going to be J codes because this is a respiratory COVID coronavirus. And then what happens when our people come in and they have the signs and symptoms, but they've just been exposed? Then it's Z03.818. And I didn't put what these codes are for. You guys, majority of you guys are going to coders. You already know what these codes are. And then what about actual exposure? We've confirmed that somebody else in the family has it. Your actual exposure, right? Or you've been to China, something like that. Actual exposure with confirmed COVID. That's another thing. Just because somebody has the sniffles in the house and they have flu symptoms does not mean they have COVID-19. It has to be confirmed. Then you would go with the Z02.828. So how do we relate this in our minds? What's the scenario? When we scroll down, we can see this is just like how we code with HIV, right? HIV is the virus. What is the disease? The disease is AIDS, which is COVID. Now, I've got that on another slide. So here are the websites that I got that from the CDC, but I want to do a special shout out for Sue Bowman. She works with HEMA, and great article that's all broken down. So you can Google Sue Bowman there, and she also has a textbook that we've used in the past. But journal with HEMA.org. Great website. Anytime you want some, I started to say state of the art. I don't think that's the right term, but up to date. HEMA is really good, and they're pumping out some great information. The thing about all of these CDCs and going to the Who, their website, it's a little convoluted, right? So what we did was, with this webinar too, is we went out, did the research for your questions, and then we're making it, we're showing it to you graphically in a way that's easy for you to understand, and abstract, pull that information out so that you don't have to go through all the CDC legalese type content. We want it quick, fast, so we can take care of our patients right away. That's it on the coding. If you have any other questions, make sure you jump out to the club, because we are discussing this, and if you've got some scenarios that you want us to give you some tips on, more than happy to do that.
Awesome.
I love
Alicia.
this stuff. Can you tell?
Thank you.
So,
yeah, go ahead.
can I mention something real quick?
Yep.
There were a lot of questions. Now, in Alicia's slide, she had mentioned that it was October 1st to April 1st. That was not a typo. That was typically we begin codes on October 1st. That's when any new code is going to start. They are negating that this time. They are allowing a special circumstance. It's not starting October 1st. It's starting April 1st. We don't see that very often. So this is a special circumstance.
Not all of the codes.
Yeah.
Right.
Right.
Only this is
That one diagnosis code. Yeah. Some people were saying, didn't you mean 2021? Because you did October to April. No, they're moving it. They're changing it. So I just wanted to make that clarification.
And correct me if I'm wrong, but from what I understand, when April 1st comes, that code goes live. However, you can still use that code if your patient came in and was diagnosed on the 31st of March. It's going to be active from October 1st.
Computers won't recognize it until April 1st. Yeah. So whatever date you're sending in, because they're actually backdating all these things still.
Yes.
February or March,
That's
depending
right.
on the circumstance. But that computer, because Medicare and CMS and all of them actually do quarterly updates, it's not going to recognize that code until April 1st. Even though we're going to assign it to a service prior to that, it will spit it out. Any clearinghouse will spit it out because it won't recognize it. But so after April 1st, it will recognize that code.
And so again, this is all for statistics because it's a pandemic, and they have to track it. So we'll talk about that more and some of the other information is going to help you because Jennifer's got some great stuff about the insurance.
I hope so.
So again, everybody's talking about how do we take care of ourselves. Just Boy found this great. Who put this out? Wash your hands frequently. I watched a video today that is, gosh, I wish I could give him kudos. I put it on my Facebook and on my LinkedIn and everything, and YouTube. He sprayed his hands and with that, or put the powder on it that spreads, and then went to a school and went to a classroom and was talking about this is a germ. And then they did the black light, and it was really impressive content, and it was something that a child can even understand. If you need to homeschool your child with information, wash your hands. But the thing you have to remember is do not touch your face. Why? Because if you guys are Star Wars fans, how did they kill the Death Star, right? They had to hit it in the right place. Eyes, nose, and mouth. If that gets in there, yeah. Well, he did that. I thought, how brilliant! You're going to have it on your hands, even if you wash your hands for 20 seconds. They had these kids washing their hands. They showed adults washing their hands thoroughly, and then they touched their face. It's still there. Handshake. It went through 9 people, and still showed up. So cover your mouth when you cough because the droplets can stay on a surface. And I can't remember how many hours, but it's more than 2 hours. I know.
I thought it was 3 days actually.
3 days? Yeah.
I've been reading so much information though.
And now my face is like itching everywhere. Yeah. Avoid crowded places. And again, just people are saying, but I'm healthy, so I can go out. Well, the thing is you are healthy. However, if you are exposed or you touch a germ, and even if you get it and you're asymptomatic, everybody you just touched spread to it. Spread to them, and they may not be as healthy as you are. So that's why we're asking people. They're asking people to stay home. Stay home if you're unwell. Just don't get out. If you have a fever, cough, or difficulty breathing, anything respiratory, just makes you susceptible. And then last and the most helpful, I think, too, because everybody's, whenever there's anything to worry about, they're hitting the Facebooks and the interwebs and talking about doom and gloom. Just make sure you're going to the authorities like the CDC and WHO. You can trust them, right? So don't be looking at anything else. Your influencer out there is not going to give you information probably from the CDC or even if they say they do. So that's why we were linking everything and making sure you can go see the source. That's who you trust. Wash those hands for 20 seconds. You can do the Lord's Prayer. Doesn't everybody know? And if you don't know that, that's happy birthday twice. It's a great way to learn happy birthday in another language in practice.
I learned something.
That's so funny you said it.
Nice.
Because I watch every day my governor gives a speech, and the guys there doing the sign language. I've been learning sign language from the 20-minute speeches from the governor.
You know what? I didn't think about that. I know sign language really, really well. And in fact, you see me using it sometimes in my hands, but when I talk. So that's great. Number 3 language in the United States is sign language. Great way to learn it, guys.
Let's go ahead and
Okay,
jump
ready
further.
for the next one.
Yes. So
Okay, let me.
there were a lot of questions as well posted while Alicia was talking about the tests and stuff, and I'm hoping that I'm going to pick up on most of those. We will keep hitting questions throughout that are posted in the chat, so if I didn't hit on what you're trying to ask me, ask it again. So Medicare is making changes almost daily about coronavirus. So somebody brought in a question saying that they were told that there's a waiver, and how is this going to affect the modifiers that we normally use? So what do we need to know in order to get our providers paid, which is probably the most important thing that everybody's worried about right now, is getting those patients seen that need to be seen, and how do we get the providers paid for seeing them, whether it is telehealth or in office. So I know that my office just had a meeting at 6:30 yesterday morning about how are we going to implement telehealth in our field of orthopedics. So there's a lot changing daily. So let's see here, go down a little bit. And so this is one thing we need to point out, it's temporary. And this is due to our emergency status that has been implemented. So CMS will allow telehealth services to take place from multiple locations to ensure that that all Americans are staying safe and healthy and receive the care that they need. So very important, this is temporary. Typically, telehealth services are only used in rural health areas. So rural areas from a designated facility that can assist patients who live out in boony areas, okay? So this is a lift of that ban of services. So this is an allowance to give additional services to patients that we don't have to worry about that criteria. We're not in rural health clinics. We're not in rural areas. Anybody, anywhere, Medicare, CMS, remember, Medicare, Medicaid services, this is CMS. So CMS says telehealth, telemedicine, and the related terms generally refer to that exchange of medical information from one site to another through an electronic communication. So typically what they had is a status point where people can use live video to speak with a provider at the other end and discuss what's going on with their problems, right? So this is a electronic format. So it was mentioned waiver, that there's a waiver. Now I want to clear that up because waiver in the health field means I'm signing off my benefits that I will be responsible. That's not what a waiver means in this case. So it's waiver 1135. That's a federal waiver that's in place. And that's the authority to grant exceptions during a time of crisis, emergency, or natural disaster. So when we had the Puerto Rico, when we have hurricanes come through, earthquakes, things like that, they are allowed to grant a waiver. In this case, this is a national waiver that's being given allowance. So the section of this act allowing this waiver is giving the Department of Health and Human Services authorization to waive or modify Medicare, Medicaid, CHIP, which is Children's Health Insurance Program, or HIPAA requirements. Now remember, Alicia touched on it. HIPAA is huge. the entire act of HIPAA. And most people think of HIPAA as private health insurance or private health information or identification. So that's not the case. HIPAA grants all sorts of things. So let's move it down a little bit. And what they're allowing here is, while under this Emergency Act, Medicare will pay for office, hospital, and other visits using telehealth across the country, as well as in the patient's home. Now that's unprecedented. They have not done that before. You had to be in a rural area, and then you had to use it from an originating site. So now they're saying an office, a hospital, or other visits, other types of services, they will allow telehealth for Medicare, as well as if the patient is in their home. So effective March 6th, so this was last week that they put in effect, and it will go to the end of COVID health emergency. We can't tell you when that's going to be. CMS will tell you, okay, it ends on this day. Whenever it has died down, I've seen reports say as long as a year, year and a half. Some people say 20 weeks. It's confusing, so nobody really knows. But at the end of this emergency time, that will stop. And at that point, you can no longer do telemedicine or telehealth unless you're in a rural area. It will go back to the original rules. Right now, they're modifying these rules. Doctors, nurse practitioners, and clinical psychologists and licensed clinical social workers, that's a lot of people included in there, can provide telehealth services to patients. So the patients can be in their home and you're providing a telehealth service to them. So under this Emergency Act, the cost sharing will be reduced or waived when paid by federal healthcare plans. They are also allowing that to be up to the provider in some cases, if the provider wants to reduce or waive those benefits for the patient. So there are a couple options in place. What can we do? We can do telehealth services, virtual check-ins, or e-visits. So a telehealth service is the evaluation and management visits, mental health counseling, or preventive health screenings. So there's a range of codes that can be used. And fascinating enough, look the number that it starts with, 99201. What does that mean? That means a new patient. Virtual check-ins are short patient-initiated communications with a healthcare provider. Those are the Hickspicks codes that can be used for that. And I'm going to go into more detail of each of these. E-visits are non-face-to-face patient-initiated communications through an online patient portal. So these are the range of codes that Medicare, CMS, Medicare and Medicaid Services, is saying we can use during this time of emergency for any patient, any reason during this health crisis, okay? So telehealth. So let's bring it down a little bit more. Telehealth is the use of an interactive audio and video telecommunication system using a real-time communication between sites. Real-time communication. You can see them, you can hear them, you're interacting. Real-time video and audio. So providers who can use telehealth are doctors, nurse practitioners, physician assistants, nurse midwives, certified nurse anesthetists, clinical psychologists, clinical social workers, registered dietitians, and nutrition professionals. That's a lot of people. Imagine if you have a staff member available that day to handle all of these, who's a PA or nurse practitioner or something. They're able to handle probably a lot of your patients done that day via telehealth. It requires an established patient relationship with the provider and the patient. However, during this time of emergency, the Department of Health and Human Services will not conduct audits to ensure this prior relationship. They are waiving that new patient requirement. If it's medically necessary, of course, you're going to have to establish medical necessity in every case, but They're not going to say you didn't know this. They're not going to audit your records from April 15th and say you didn't know that patient ahead of time, because you're acting in good faith to provide services to a patient. It requires a provider and a patient. They can't be in the same location. You can't have a patient come in and be talking to you through the glass window. That's yes, you can see them and you can audio them at the same time, but you're in the same location. And any diagnosis is eligible. Anything. It's not related to COVID. It doesn't have to be specifically related to COVID. So you have a patient who has to follow up for their hypertension, but they don't want to come out of the office because, you know, they were sick last month and they just don't want to take a chance, or they don't have transportation. The bus systems have shut down or condensed their hours in a lot of places. So maybe they don't have transportation to get there. So they need to be able to follow up. So any diagnosis can be used, but the services still have to meet reasonable and medically necessary criteria. So even though you may have that, so think about real quick, I mentioned this to somebody who actually reached out to me via LinkedIn today, and they said, okay, how do I do this? And I said, well, yes, you don't have the exam requirement, but what are some aspects of the exam that they can do face-to-face without touching the person? We've got alert oriented. We've got, maybe in my field, orthopedic, they can still see a range of motion. Here, go up, turn sideways, let me see. They can still assess a range of motion, possibly edema, maybe, you know, just think about all the different exam requirements that possibly they might be able to reach. Maybe. You know, there are some, but this is going to be a time where we're going to use our best judgment and say, you know, this is what we're trying to do for this patient. So again, they bring these bullet points out really nicely on this Medicare link that I provided, but the visits are considered the same as in-person and paid at the same rate. So even though you're providing it telehealth, they are paid at the same rate. The previous originating sites of office, skilled nursing, and hospitals can be furnished in any setting and in the home. So previously we had criteria, now it's any setting. The providers may reduce or waive the cost sharing. That's up to the provider. And you should notify your patient of what you're going to allow, because everybody's hearing free right now. Modifiers will still be in use to indicate the type of service that you performed. So whatever modifiers we were using before for telehealth, we're still using them for telehealth. And the place of service is O2, because you have to indicate this is telehealth. So there is a link there as well. Now, some of the other codes we can use are virtual check-ins. So I'll go over these other ones quickly. We want to go down a little bit. So the brief, remember, it's a brief communication. They say typically 5 or 10 minutes, but via a number of communication technology modalities. So this is right from CMS, including synchronous discussion over a telephone or exchange of information through a video or image. So if somebody's sending an image to a doctor via email and say, look, this is what my operation site looks like right now. Is this healthy? Do I need, you know, or some kind of, you can imagine what kind of pictures or videos people might send in. It's patient initiated, however. The patient initiates this. The provider can educate their patients and say, this is available, you can call in, but it's patient initiated, and that has to be documented, as well as the patient must consent to receive this. They have to document consent from the patient. Communication cannot be related to a visit from the previous 7 days and does not lead to a follow-up visit in the next 24 hours or your soonest available. Say it's Friday, 24 hours is Saturday, you're not open. Soonest available would be Monday, right? The provider may respond to the patient's concerns by telephone, audio, video, secure text messaging, email, or a patient portal that you may have through your online website with your company. Cost sharing does apply. They're not waiving that. Cost sharing will apply. So this is only established patients. They have to be established in this case for a virtual check-in. You have a broader range of communication methods, which is nice, but it has to be initiated by the patient. And then the last one that we have is our sorry, our e-check-ins, our e-clinics. As if we go down a little bit more, e-visits. So these are non-face-to-face, patient-initiated, again, communications with the doctor's office through an online portal. Now, this is a general inquiry that can occur over 7 days. So say they're constant, back and forth communications through the portal. The patient has to consent to receive these. That needs to be documented. Remember, if these are in the portal and email, they could be tied into your EHR system. So all this communication is documented then. They have to consent to receive it. It requires a clinical decision. That would be the same as if you made it in the office. This isn't just, hey, how are you doing? What's up? How's your medication? This is, okay, I see what's going on. Yes, you're having these symptoms in the evening. They're getting greater. The same kind of information they would take if they're sitting right there. It's just it's happening via a different communication method. And then there are CPT and Hickspicks codes. It depends on the provider who's giving the service. A doctor or nurse practitioner has CPT codes. A physical therapist, occupational therapist, speech pathologist, or clinical psychologist have Hickspicks codes that they can sit in for e-visits. So these are only established patients, again, in any location, initiated by the patient. Cost sharing may apply, and it is not eligible if they follow up or do telehealth in the next 7 days. So if you're billing a different telehealth visit, within the next 7 days, you don't bill for an e-visit. They're all combined. You're going to be using all that decision-making process you did in the e-visit while you do the telehealth visit within the next 7 days, or coming into the office in the next 7 days. I believe that was all we had. Oh, sorry, the very most important thing, HIPAA waivers. So the Office of Civil Rights has asked that they will waive the discretion and any penalties, because if you violate HIPAA, I think the penalty, they change every year, and off the top of my head, starts at $35,000 per charge. They will waive any violation against providers who are servicing patients in good faith during this emergency through telecommunication technologies. That's why those remote systems are established in a site, because they're secure. But if you're doing it via FaceTime, Skype, any other type of format that they might have or they might be contacting you on, and you're acting in good faith, they will allow those services, because when you're on FaceTime, you got people behind you, they might have people in the area. You're violating HIPAA now. You might be giving away private information or information regarding the health of the patient. So if you're using another form of non-secured communication, they will waive that during this time as well. But remember, this all ends when the CMS says the emergency ends. That's when it ends. So I know we'll probably still have questions about exams, or not exams, the tests and free, and I will be talking about that when we get into some of the commercial insurances as well. And I just see questions just popping up out of the corner of my eye this whole time, so we'll try and get to some of these questions that you guys have too.
Ooh, I've been answering questions behind the scenes. I'm glad I muted myself, because otherwise, Boyd would be saying, I hear you clicking. I hear you clicking. I'm going to mute you. He knows. He's a sound guy, though, by trade.
Alicia, read off this review for me, please.
Sure. Thank you so much. The BAT system really helped me, and so did your time management techniques. I stuck to them until the end, even when I started to panic and passed. Thank you, Heidi. That came on February 10th. Man, we got one the other day that was so fabulous, and everybody was scrambling and to ask her if, hey, do we get to, can we put that up and share it? Because she really brought out some great stuff. Heidi, thanks for giving us that review. Boyd goes through and scours them and gets those current reviews, so you always know we're not grabbing something from 3 years ago and that we've like gone downhill, right?
Yeah, and it's important to
You
note that
guys,
everybody does this voluntarily. So I like to make sure that we
yeah.
acknowledge these people who are taking the time to acknowledge us for helping them with their careers and such in education.
I just typed in one more response to a question. I was trying to type real fast before Jennifer got done. Don't forget, if you stay till the end and you stay afterwards, we have this chat, kind of like after the webinar's over, that we'll address some of these. But, we don't want to stay up all night. And we already don't know if Jennifer has COVID-19 because she's in there hacking, it's like, oh my gosh.
That's from February 14th, man. I haven't gotten rid of that, which is why I am trying to stay away, because do I have an immune compromised respiratory system? So
I have a son with RA, so we forget that he's immune compromised. We forget about that. But stay till the end. But the best way, really, guys, to carry on this conversation, and not just us as subject matter experts, but everybody else that's on the CCO club, we've got several SMEs in there, is to go join that club. You guys, this is a great time to do it. So user-friendly and engaging. Okay, so are we ready for another one? Because I think we're going every other. I think it's my turn.
Yes, but let's talk about the spring sale here first. We have a spring sale with 30% off courses and blitzes, and that is going on till March 21st at midnight. That's this Saturday. So you can get access to that at cco.us/spring sale.
A little tidbit: if you purchase one of our courses, you're in the club. So while you're doing the course, you get that club membership. So maybe it would be a good time, since if you're going to be home working remote, take advantage of picking up another credential, or just taking one of our courses that brings up your knowledge base a little bit higher. So, and how better to save money than take advantage of it being on sale. But you know what? They wouldn't let us call it a pandemic sale because that was just, too soon, as those comedians say. All right. Signs and symptoms of the coronavirus. How do I know what to code when a person has a virus? Everyone is talking about this new coronavirus, but not all the signs and symptoms are the same as others. Actually, that is a very valid point. This is one of the early questions that we got in the topic requests. And I think now we probably established, most people are aware now that this COVID-19 coronavirus is a respiratory, comes from a respiratory background. So what I wanted to do is give you a little bit of information. Coronavirus has been around forever, guys. If you go look at a bottle of Lysol, it states it helps with, it gets rid of coronavirus. How long is, and that's been on that forever. Go look at that ancient bottle of Lysol you have under your kitchen cabinet. So coronavirus is a term that is under an umbrella. It's kind of like, think of COPD and all of the diseases that fall under COPD, right? Respiratory type things. So that's what coronavirus is, a multivirus type umbrella. And then once we get one, it's named by the WHO and CDC. They all get together and they come up with a name. Thus now we understand that the given name for the Corona-19 is COVID-19. There's even a timeline as to the date when they officially named it COVID-19. Right. So I don't know if the next baby boom from all this sequestering is going to be COVID babies or the COVID generation, but I think so. So the disease itself is COVID-19. The virus is the severe acute respiratory syndrome coronavirus 2, which is SARS-CoV-2. Do you remember when SARS came out before? The same thing happened. Everybody, it wasn't a pandemic though, meaning it didn't hit every continent, but they named it SARS, right? So we had SARS, which was the disease, but its virus was called SARS something, like Cova 1. Well, COVID-19, that coronavirus that we're all talking about, that's the pandemic, is a SARS virus. So now you have an understanding. The disease itself is COVID-19. That's its official name now. The virus itself is a SARS-CoV, CoV, or however you want to say it, 2. Okay. The best way to give you an example of how to think of that in your brain is that HIV is the virus that people get. You can be HIV positive, right? But you don't have AIDS. The disease is AIDS, but the virus is HIV. Okay, so if you think of it that way, now think of the rules that apply with coding HIV and AIDS. That's the same thing that applies as the rules when we're going with COVID-19. So does the patient have a coronavirus? Yes. Well, what's the disease that they have? COVID-19. They could have a SARS. They could have SARS-1. They could have MERS. They could have several. They could have the swine flu. They could have the bird flu. All of those are coronaviruses that have a name. H1N1 is the swine, I believe. My daughter got that way back when, and I don't know how the rest of us didn't get it, but they did a swab and they confirmed it. So she had the disease from that virus. So again, if you want more information about that, there's a link from WHO that I put on there, and they were stating that they named the new virus on February 11th, 2020, the SARS-CoV-2, right? And then it got its official disease name, COVID-19, just a few weeks ago. Because as you scroll down, let's talk about this also more in depth to give you a background understanding. I love this disease process. What you need to understand about this particular disease, COVID-19, is why it scares people, why the medical field and the CDC, they're all, they're saying, well, what's the difference between this and SARS? Besides the fact that it became a pandemic, meaning it's every continent now, it's everywhere. The fact is that it's new. Now, when we got SARS, it was new. And there was a learning curve. How's it going to affect everybody? How's it going to exacerbate itself, right? What are the signs and symptoms? What is going to, what is going to happen? Are the people going to get ARDS? Are they, or who is more susceptible? And most of them are pretty much the same. But another thing is, what's the incubation period? Now, it took us a while to figure out what MERS and what SARS, what the incubation period is. Think about chickenpox. Now, if you're my age, you remember, and my parents, they used to, when someone in the community got chickenpox, you sent all of your kids over there to be exposed, and that you knew 14 days later they would break out in the chickenpox because you wanted to get it over with, right? Well, now there's a vaccine for chickenpox. There's the varicella vaccine. So our kids now, future generation, are not going to have chickenpox like that, and we don't want them to be exposed anymore. But we knew the incubation period. We knew that once you were exposed, and that's why we have a code for exposure, and that's why we have the codes that we talked about previously, right? We need to statistically track that so that we can understand what's the incubation period for COVID-19. And they understand now that they're estimating, because this is an estimation, this is new, never been out there before, 4 days. And then they're saying but it could range from 2 to 7 days. Now, that's different than SARS and MERS, okay? For it to be 2 days, that was problematic. Okay, so again, learning curve. We needed to know that. That's why we do this for statistic purposes, so the providers can understand the disease process and treat the patients and get the information out to the patients and their caregivers. So the COVID-19, 14 days, you're at risk, okay? And the quarantine is not, you're quarantined for 14 days because then they say you might not get it. So how long does a person have to, if they have it and they have no more signs and symptoms? So the current CDC guidelines is it's okay to release somebody from isolation. It's made on a case-to-case basis. So we have to understand, is this a healthy 18-year-old that got the coronavirus and they're going to spread it versus somebody that's 75 years old that had it and they're recovering. So it depends, is this person going to go to school? Maybe they need to stay home a few more days. 75-year-old, their range of network of who they're going to expose, not always the same. And the 75-year-old's network of friends is more susceptible than an 18-year-old, right? So they're thinking all this through. So the CDC said the patient has to be free of fever without use of fever-reducing medication. Meaning you're not on ibuprofen, you're not on Tylenol anymore. And you don't have a fever. You no longer are showing the signs and symptoms, including a cough. So that dry cough, not there anymore. The patient has tested negative on at least 2 consecutive respiratory specimens collected at least 24 hours apart. Okay, then you can get back out into the public. Someone who has been released from isolation is not considered to pose a risk of infection to others. Okay, so who makes these decisions? Your provider makes these decisions, and this is what the CDC says that they're going by. So you're going to be tested more than once after you have no more signs and symptoms if you have tested positive. Okay, now on March 7th, which was just the other day, they made some revisions. They tweaked it, and they said if you have confirmed COVID-19 and the epidemiology data from China, okay, including the characteristics of the COVID-19 admitted to the intensive care unit and pediatric cases, okay, they made some revisions. They're saying that the SARS-CoV-2, which is, right, the virus that we're talking about that causes COVID-19, that the shedding among asymptomatic persons and data that report says that it's viable from stool, isolated from stool samples. So why are we washing people's hands? We have to relearn how to wash people's hands. It can go through the stool sample. Okay, scrolling on down, let's see what else we need to know, because we're talking about respiratory all the time, but we're not talking about other ways the germs can be passed. Also, accessibility for investigation. The therapies for the COVID-19 clinical trial enrollments are happening in the US because, again, it's brand new. We don't know. And that you have to stay on top of what's happening with the pediatric surveys. And we got to be careful with sepsis guidelines. So go back to your coding knowledge on coding sepsis. A child gets pneumonia, they have COVID-19 positive, and now they have, it could easily run into sepsis because it's a viral thing and organs can start shutting down, right? And this might not be the kidneys, it'll be the lung system. And I think that's all. We talked about the signs and symptoms already. Those R codes: cough, fever, right? And shortness of breath. So virus signs and symptoms for COVID-19 are those 3, super easy to code. And we've been using them, not nausea, vomiting, and stuff like that. Now they might do aches and pains, malaise and fatigue. There's a code for malaise and fatigue too that you could use. All right. I hope that was informative.
I think I jumped
Yay,
ahead,
Jennifer.
so we'll go straight into the next question. Actually,
this one's short.
Yeah, go ahead. Yep, perfect.
Yeah, this question's rather short. It seems like it would be convoluted, but so if a clinic worker, a provider also works over at the ER, can they bill a separate E&M charge for both providers if the patient was at the clinic and then the ER? So they say, for their example, patient seen in the clinic for possible COVID-19, and then they send them to the ER. So basically what that boils down to is, how do you bill? So there may be a scenario where a patient provider is at the clinic and then they're at the ER as well. But you got to look at that tax identification number. So does that ER or that facility that they're at, that ER, do they also own that clinic? Because then they're most likely billing under the same tax ID. But does the provider work independently and then need some extra money to pay off their medical bills or, their school bills? So they also work at the ER as a hospital employee. That may be a different tax identification number because they work independently at a clinic and then they're a hospital employee in the ER. So that really is about the tax identification number. So if we scroll down a little bit, I break it down a little bit more about the tax ID. So if they're working under that same tax ID, I'm going to go into that, and that is following CMS rules. If a physician works independently and then works at the ER separately, in that scenario, they could, in theory, bill two separate visits because they're under two tax identification numbers. Unfortunately, you get into the ethics there. Would you do that? You already know this patient, you've already treated them, you've already seen them. I always err on the side of caution and just follow CMS rules. But if they work independently and then maybe they're on call that evening and then they happen to see the patient again because they were called in, or they saw them at 4 o'clock, they get off work at 5, they go call, the ER said, please come over here and see this patient. So that provider would bill his own patients he sees under his own tax ID. So now we're back to that CMS rule. So if they're admitting them to the hospital, becomes one thing, because if they came from the ER, you saw them in the office, they went through the ER, said, okay, you need to get admitted in the hospital, that's also going to fall under the CMS rule that you can only bill one visit in one day for the same provider seeing the same patient, and you would bill the inpatient admission. That's what you would bill. You can assess all of that information you took from the office in the ER and use it to level your inpatient visit, but you only bill one patient one day for seeing the same patient. So if we go down a little bit, CMS, this is what they actually say. This is from CMS, that physicians in the same group practice who are in the same specialty bill and be paid as though they were a single physician. So if more than one evaluation management is provided on the same day to the same patient by the same physician or another physician in their group, only one is reported unless it's for different problems. So instead of billing separately, they take all that information, they combine it, and come up with the appropriate level. So down a little bit more, so what if that same provider saw the patient at 2 separate times on the same day? It could be possible to do that, yes. So say they saw them during the day to follow up for diabetes or skin condition or rash or something, and then they saw that patient that evening because they went home and they started feeling well, and they're concerned because they have other problems, so they thought they might be, they need to go to the ER for COVID related issues. So those are 2 separate encounters. They saw them in the day for their skin rash that they're following up on. They saw them that evening for COVID. You can bill that instance. The second visit gets a 25 modifier. So it is a separately identifiable visit, meaning a 25. So they did come out the X modifiers. The X modifiers are very confusing, but there is XE that says a service that is distinct because it occurred during a separate encounter. And we think, well, okay, these are separate encounters, except X modifiers are a replacement of 59. There are additional reasons for 59. 59 is a procedural modifier not an evaluation and management modifier. So you cannot use an X modifier in that case. So if the problems were not the same and we're under the same tax ID, can we still bill them? You'd level that E&M. So if they weren't the same and we saw them in the ER and we also saw them in the office and we sent them to the ER, how do we code that? Say somebody else happened to see him in the ER and we sent him over there. Did we receive enough information to properly level our evaluation and management for that patient before we sent him to the ER? And if we did receive all the criteria that we need and is medically necessary, then we would bill that visit under whatever information we received for that level. And then maybe another doctor saw him over at the ER for something else, or the same thing, but we're two separate entities, two separate people. So we can still bill our office visit if another doctor happened to see him over in the ER. So it may seem like, well, we sent him to the ER, and we happen to see him over at the ER, well, then we're using all of our information in one. We're billing one visit. You can't bill multiple, even though you send them to a different place of service. So that one's in a nutshell. That one's pretty quick.
Thank you.
Yep.
So we did want to reach out and just ask where everybody is around their work status right now. So we're going to launch a poll, and hopefully things won't mess up on me this time, because we'll stay in the same webinar here.
While he's doing that, okay, so we want to know your work status currently, but I have to say, Barb, who's also one of our frequent flyers, says the WHO has determined that our dogs do not catch this virus and no longer need to be quarantined. Thus, who let the dogs out?
Mm-hmm.
What's your work status? Remote, in-house, temporarily laid off. Sweet and simple. We want to know. And when we say in-house, are you work in a facility or an office? Love to see what your thoughts are, guys, on that. There for a while, they were stating they didn't know if the COVID-19 could go to your pet and back and forth. And so that is a really good point that Barb makes. And because very seldom do these coronaviruses go back and forth, but we have to remember they do come from animals. And so this one, I believe, COVID-19 came from bats, and that's why you get the swine flu and the bird flu and stuff like that. And so this was in the media, and this was talked about, and the research I had done that had said, no, they haven't determined it, because it's brand new, guys. So again, good to know, Barb. Thank you. Who said that now? So go love on your pets.
Yeah, it's not determined yet. So, yeah.
Oh, not determined? I thought they said they did determine.
No, they haven't determined yet if it affects pets or not. So, yeah.
Okay. Well,
oh, wow.
Barb.
Oh.
Remote. Excellent.
Wow.
The people on Facebook can't read it, so read it off for them, the stats, please.
Oh, sorry. Yeah, so
Remote,
currently, what is your work
60%.
status? Yep. Go ahead, Alicia. Sorry.
In-house 31%, temporarily laid off 9%. That is the most that we've had remote in a very, very long time, guys, for our statistics, right, Jennifer, wouldn't you say?
Oh, yes. Yeah. Yes.
Sorry, guys.
CCO is completely remote, so this is not new to us, but again, it's I suspect that once you go remote, you don't go back. These entities will start saying, hey, that worked out pretty good. We're not going to pay to turn our lights on in the office. You go work from home.
Well, the opposite. In my office, they said, yep, you're the last person to work remote. We're not letting anybody do it anymore. So.
That changed.
Oh.
Okay, Alicia.
So this is a great topic, and we did a little bit of this on one of our Facebook, our CCO live events. We talked about situational awareness and stuff, but coronavirus safety in the workplace, and not just COVID-19, but this is stuff we should implement going forward. I manage a busy office and do not have the choice for our staff to work remotely. Any tips? Absolutely, we got tips for you. I wanted to let you know that 2 resources I used for this, and one was the CDC, and the other one was Escape the Wolf. Now, we all know the CDC, and this came up, the COVID-19 in the U.S. as of yesterday. And you can just go to the CDC and you'll be able to look at this graph. It'll change. However, I thought it was really important to understand what states are being heavily affected. So if you've got a major airport, international airport, yeah, your area is affected. But notice we've got the West Coast with California and Washington, and then I'm sure Oregon is right there too. And then that other dark spot, that's New York. So that being said, this is how many cases have been verified. The other place that I wanted to tell you about that you guys are would be very beneficial, especially if you manage an office, the Escape the Wolf, and it's just escapethewolf.com. You can contact Scott at escapethewolf.com, and they have a crisis management pandemic PDF. It's a booklet that they give out. However, they've offered in PDF free for you guys. So just email Scott at escapethewolf.com and they will give that to you free. They also have online training. I actually took this and used it for my CPCI teaching, but you can use this for CTUs. And it's just good they offer training for everybody. So if we scroll down a little bit, let's talk about what we know so far and what's going to be beneficial from you. This came from the CDC website. When is someone infectious? The fact is they don't know because this is so new. Now, statistically, they'll be able to go back because of the codes that we are using and track it. And they'll know every day, they know more and more because of these codes. But they're saying the incubation 2 to 14 days, most of the time it's not 2 days. That's very unusual. So the COVID-19, it's really not known. That's important. Also, as you read through this, and I'm not going to read this word for word, but the thing is it's asymptomatic. You can still spread it. Just watched I think it was on Fox News. I can't remember where I saw it, but they interviewed a nurse who lived in Colorado, had gone to Hawaii, came back, and she said, very healthy. And her husband, she said, oh, she kind of felt, a little off, but she knew it was because she was really tired from this trip and it was kind of hectic. She got home, came down with the symptoms, tested positive. Wow, right? So she said her worry is that, did she get it in Hawaii or did she get it in Colorado before she left? And they backtracked and decided that no, she was exposed and got it in Colorado, went to Hawaii, exposed everybody there on the plane trip over and the plane trip back, right? And she was symptomatic. She didn't feel good. And and the only reason she went in is because she was a nurse and she started having severe shortness of breath. Otherwise, she just thought that she, just might have some symptoms and tested positive. Her husband, however, directly exposed, of course, the same as her, just ran a slight fever. So he was asymptomatic, but still contagious. So asymptomatic with the SARS virus, this Cova-2, but it's not known how the asymptomatic people are transmitting this. So we just have to assume they're transmitting it just like somebody who's symptomatic. The pre-symptomatic transmission, we don't know. 2 days incubation, wow. So she felt wonderful, except on the flight back. And I don't remember, it's a very long flight back. So that whole trip, but they backtrack and realize that what her exposure is. So what they are suggesting is they know the incubation period could range from 2 to 14, and they're using the existing literature from SARS, from before, and MERS. So the SARS-CoV-1 and MERS suggest that this incubation is going to be 2 to 14 days. So that affects the workplace, right? If you have signs and symptoms, do not go to work because you are going to infect everybody else. So the cases of COVID-19 in the US, if we scroll down a little bit more, this is directly related to the travel information, okay? And they are stating that they already know this. Travel related exposure in the US, 269. Now, this was as of the 18th, okay? Then close contact, 276 people that were confirmed because of close contact, 269 confirmed because it was travel related, like the nurse that went over and came back. The under investigation ones is 6,493, total cases over 7,038. So they're still investigating, and every day that number probably changed. There's a link for the CDC on the cases related to travel related versus under exposure. It's a fabulous link for you to go in and stay on top of. It looks like Boyd brought that up. Total cases now, as of since the 18th, is 10,442, deaths 150. Okay, there's some other links that we've used in previous things. It says jurisdictions reporting cases, 54. So with 50 states in the District of Columbia, Puerto Rico, and U.S. Virgin Islands. So that's the jurisdictions that are used for that. I think we scroll down just a little bit on the answer sheet. I think there was something else. Okay, again, reiterating the signs and symptoms for COVID-19 are fever, cough, and shortness of breath, and malaise and fatigue, because if you get the flu, everybody gets malaise and fatigue. So we're not talking about any other, bowel upset, stuff like that. It's not running the digestive tract. This is one that affects the lungs. The other question was, can people who recover from COVID-19 be infected again? They don't know. And all the stuff that I was reading from reputable sources were saying they really don't know, but they think that just because you've had it once doesn't mean you won't get it again. Now that's scary too, right? So that's another reason they don't want you going out and infecting people, because this is so new, right? That we need to be cautious, and that's why everybody is being quarantined. If we knew, like SARS and MERS, we know. So with this, it's different, and thus it's a pandemic. We can only go by what we know from MERS, which they said it's unlikely to reinfect shortly after they recover. But again, it can happen. Chickenpox, right? We used to say, well, once you got the chickenpox, you didn't get it again. And then later they said, when my children were, if you just got a little bit of chickenpox, you didn't break out all over in spots, but you were confirmed with chickenpox. If you didn't get a bad enough case, you could get it again. People got it twice. So they're still learning. What do we need to know in the workplace? This is what we got from Escape the Wolf. I did get permission from them to just grab this little bit of information, but I encourage you to reach out and go to that Scott at Escape the Wolf. And it says that planning is very, very important. And they go into more depth. I just kind of highlighted. So in the workplace, what's the first thing you need to do? You need to get someone appointed to be the coordinator. Now, that's not the person that's going to do everything. That's the coordinator. And that's just pure leadership, right? So then identify who your leadership people are going to be that are going to take those roles. We're going to identify suppliers. Who's going to get you Kleenexes in the office? Who's going to get the sanitizer? Who's going to be the person that's going to go out and run and get paper for you? Or is it going to be delivered? What did you do before? Maybe who goes to the bank? Who takes the money to the bank every night? Things like that. Because we're not just talking medical field, we're talking workplace, every workplace. So whether you're a fast food restaurant or you're a bank or you're an office that provides a service, heating and cooling. We've got several business owners in my family that I'm thinking of. Cross-train employees. This is essential, because if one person goes down in a small office, they're the only ones that had that skill set to do their job. You better cross-train somebody else, right, to be able to take over. They may not be the best at it, but if Ethel's the only one that knows how to do a specific job, then you're in trouble, because if Ethel goes down with the signs and symptoms and she's quarantined. Review financials. Hey, how long can you go with a tightened purse strings in your office or for your job? Is this going to put you under? Do you have to lay people off? Can you make people work from home? If they're going to work from home, do they have VPNs? What do we need to do? So review your financials ahead of time. This is stuff that should be set now, so that in the future, if this happens again. Travel restrictions, pay attention. The CDC, how's that going to affect your business? If you have people that are full-time, they travel for the job. Reliable fact information. Don't be looking up stuff on YouTube and Wikipedia. No, go to the CDC and WHO. That's who's going to give you reliable information. Communication. Are you set up for proper communication and your people working remote? Do you need to even put up a chat group so that everybody can get together on the phones or IM? Are you able? We monitor our internal people. We're already monitoring that Zoom is having problems because everybody's trying to do meetings that way. Go to webinar. They're having glitches. Why? Because it's overload. This is not what they expected. So communication and work drills, plan it out. So now that this has happened, and if you're, the good news is, go ahead, look at what you can do in the future if this happens again, dry run. Note that COVID-19 is a viral flu. That means you can't go get an antibiotic. There is no cure. There's nothing that you can do. All you can do is treat the signs and symptoms. So Barb mentioned Tylenol. The CDC is saying Tylenol works better than ibuprofen for the fever, reducing the fever with COVID-19. So again, that's good to know. The flu is contagious. Everybody knows this. This is common knowledge. And we now know that COVID-19 is affecting the lungs. So therefore, take those precautions. Don't go to work if you're sick. Plain and simple, don't go to work. What else did they say? Following up. And again, this is all from Escape the Wolf. So I encourage you to go there and get that information from. This is just a tiny glimpse of what is in this multi-page PDF that they'll give you for free. Influenza, doesn't matter what kind you get, whether it's COVID-19 or not. It's a dangerous infectious disease. You see these people, when it was first being talked about, they kept saying in the media, hey, don't panic. More people die of the flu than all of this stuff. But then it became a pandemic, right? Because it's so infectious and it's dangerous. Now, if one of us get it, we're probably okay. However, I mentioned my son has RA. He's autoimmune deficient. So if you have a family member that has COPD or any type of lung issues or any type of doesn't matter what age they are, this is dangerous and they can go downhill quickly. It circulates very quickly in the workplace. It's important. Don't come to work if you have a fever or chills or body aches. Malaysia, which is Malaysian fatigue, being tired and worn out, unusually so. Sore throat, cough, congestion, or runny nose, and increased sneezing. Those are the things that are, hey, this is the trigger, okay? So watch out for that. Now, I just traveled 3 states to get back from my vacation, and the barometric pressure of going from 3 states with different temperatures, we're all a little, off and stuff, but we know what it is. So we're still quarantining ourselves. Discontinued transmission. This is also based off of the CDC and where you can get the links. And again, I just copy and pasted this from the CDC. You can footnoted it for our club members, and note that for recommendations for the COVID-19, they have put out this interim guidance, and very good stuff. Excellent stuff. So 2 great resources. Again, CDC, a little convoluted, not easy to read, however, that's why we offer this stuff in an easy format for you. So workplace, last thing that they said in Escape the Wolf, and I thought I grabbed this because I thought it was very apropos. Just to highlight things that need to be cleaned in the office or the workspace that we forget. Doorknobs. Our friend Don Self kept saying, he's signing off, and don't forget, stop licking doorknobs. Frames, handles, think about the frames, desks, of course, hand railings, light switches. When we went to the gas stations or the rest areas, they completely covered up the drinking fountains and put yellow tape all around them. No drinking fountains. Elevator buttons, shared equipment that you don't think about, the mouse. Don't share your telephone. How many of us say, oh, here, give them the telephone, say, hey, put your number in for me. Gym areas, gyms are shutting down. You don't need to be going to those. And don't forget the floors. Don't forget your floors. The 5-second rule, no more. Can't do the 5-second rule anymore. I'm not sure, but was there anything else in the bottom of that? I think there might have been a little bit more, Boyd. Right. Don't forget the kitchen and staff rooms, wherever you prepare food. They were just talking about, those reusable bags that they want everybody to use to save not using plastic bags, fully contaminated. You guys, you got to put them in the washing machine. So stop using your reusable carry bags and go ahead and use plastic bags right now, because the grocery stores are full of germs, and they stay in those they harbor germs in those plastic bags. Countertops, refrigerator handles, microwaves, coffee pots, and tables and chairs, as I rub my nose because all this makes my nose itch. So again, Pandemic Handbook by Escape the Wolf, and share with your friends. I would encourage you that you would give them Escape the Wolf also, because that booklet is excellent, very easy to follow. Yay! You guys, the CCO Club has everything that you need. Hot topic. We're all talking about it in there, and so user-friendly. But you get more than just topics like this. We got lots of CEUs. You get all of these slide decks and these links that you're able to access because of that. It's not just coding. We have billing and other topics, and the extended product support. We really like our club members, so we take care of them first. They get priority with everything, and we can tell if you're a club member or not. It pops up for us to know, so take time to do that.
It is the time of 9:30, or just a little bit over. Oops, can you hear me? Yes.
Yeah, we can hear you.
And this is about the time where we come on and we tell everybody who our winner is for our drawing. So I want to do that, even though Jennifer's got still one more question that she's going to answer for everybody. And our winner is Tina Marie Davis. And I believe she's still
Tina
here.
Marie Davis.
Yes. So Tina Marie.
Congratulations, Tina.
Reach out, and what's on your screen is available to you now. So either a Blitz video package, 1 year CCO Club Basic, or a 1-hour session with our team.
That means that this 1 year of the CCO Club, you're in, Tina. If you pick that, then you'll have access to everything that we talked about tonight and all that other stuff and support. So congratulations, Tina.
Awesome. So let's go back to Jennifer here, who's going to do our last one.
Yeah, and I thank you guys for sticking around. Normally we're done usually about 9:30 and we answer general questions, but this was just so much information this time that I had to make sure I wasn't muted, that it's just taken us a little bit longer. So I appreciate you staying till the end to hear everything that we have to say. Now, Medicare, of course, CMS, they are really sending out updates daily. I used to joke before that I get something from them every day. I am getting something from them every day now. So they're trying to stay on top of this. They are trying to get it out as much as possible. But what about all the other carriers? What about Aetna, Cigna, United Healthcare, Blue Cross? What are they doing? Especially if somebody doesn't have a large elderly population. Maybe, they don't pediatricians, some family clinics maybe may not have a large Medicare population, which CMS would affect Medicare as well as Medicaid services. So we'll go down a little bit and we'll break down some of these commercial insurance carriers. Now, this is where a lot of those questions came in. Well, what about free? What's free? They said that they don't have to pay for things. This is where we're going to get into that, okay? So only about 15% of our population is on Medicare and another 20% use our Medicaid services. So 35% of the population across the United States is affected by what CMS says. So the other 65 have all of the other insurances that are out there. So let's look at what some of them are doing. So the American Health Insurance Plans, I went to their website and they have been updating it. Their last update was March 6th. They did include a more recent update for a specific insurance carrier, and I have given their website as well. But they have pretty much all of the carriers listed there and what they are doing, how they are responding to the coronavirus and COVID-19. So Aetna is going to waive copayments for the COVID-19 diagnostic tests. They will have 0 copays for telemedicine visits for any reason through June 4th. So most of them have a 90-day period that they're doing. They'll allow their Medicare Advantage plans, people with the Aetna Medicare Advantage, virtual management and monitoring. So something special for them. Patients with COVID-19, this was kind of interesting. They're going to send them a care package. They're going to send them necessities, toiletries, items that they may not even be able to get from a grocery store or something because they can't get out right now. And they are offering home delivery of medications through CVS, so for no fee. So some of these are doing some things that we're thinking, well, that's not a benefit to me, but it may be something you can pass on to your patients, your family member, your aunt, your uncle, your grandparents, so that they understand what's going on as well. Now, Anthem had the most recent updated information. Granted, some of you may not use some of these carriers, but they will waive copays and deductibles for COVID-19 diagnostic tests, and they will waive the COVID-19 visits for doctors, urgent care centers, and ERs. So if it's in relation, if it's stemming from that COVID-19, the patient's not going to pay a copay or deductible. They are also allowing refill of 30-day medications early because they don't want people getting out there right now. They want them to stay home. And for 90 days, they will waive the cost sharing of telehealth visits, including mental health, which is pretty interesting. A lot of these sites did mention what kind of stress and anxiety this is causing the patient. And we've seen some people put comments here. Now I'm terrified of all these places I touch, and to think about that, this could really increase somebody's anxiety and stress during this time, which is not healthy for a person. So they are including mental health in a lot of these. The Blue Cross Blue Shield Association is a membership of 36 Blue Cross companies across the United States. So of those that belong to the Blue Cross Blue Shield Association, they are waiving the prior authorization to get a test. So if it needed prior authorization, they're not going through that process, and will have a no cost share to members for COVID-19 related services. They will waive the prescription refill limit on maintenance medications, and they're expanding access to telehealth, and they're using a nurse hotline. Now, the website does include all of the other Blue Cross plans. They're all kind of similar, but Massachusetts, Michigan, Kansas City, Minnesota, Nebraska, New Mexico, all around the area. Capital area, DC, Maryland, Florida, New Jersey, which is Horizon, Pennsylvania, which is Independence. So they may go by a different name, but these are the states that they work with. So for example, Blue Cross Blue Shield of Alabama, they will allow up to a 99213 to be submitted via telehealth through April 16th. And then Blue Cross of Massachusetts is waiving the co-sharing for members for telehealth visits in relation to treatment of COVID-19. Now, some of them are being specific to only COVID-19. Some of them are allowing any type of telehealth visit, where CMS is allowing anything. So we really have to look at the insurance carriers that you belong to and see what they're offering. Blue Cross Blue Shield federal employee is waiving copays and deductibles for COVID, waiving prior authorization, no cost sharing currently for a 14-day supply of medication, and waiving copays for telehealth, again, in relation to COVID-19. I have Cigna. They're covering the test, covering the cost of the test with waived copays through May 31st. They're waiving out-of-pocket costs for related visits, and again, free home delivery, 90 days medication. Humana is waiving the testing fees, telemedicine costs for urgent care needs. That's a little different for the next 90 days, allowing early refills. And United Healthcare, our other carrier, they're in relation or through April 3rd, but they do have a member copay will be assessed, and they require a GT or GQ
Jennifer,
modifier.
just pause your camera for a second because your audio
Sure.
broke up. Just pause it and then start
Sorry.
with United Healthcare maybe for a
Sorry.
second there.
Okay, pause it again or no?
You're good. You're good. Go ahead.
Okay. All right, so United Healthcare is waiving the cost in relation to the testing. They're allowing telehealth from home or any location through April 30th. They, with members, do have a copay though, and they are asking for the GT or GQ modifier and an O2 place of service. Now, the American Health Insurance Plan has a site, and that's the link for them, and they list all insurance companies. I mean, Centene, Emblem Health, Kaiser, CareSource, all the insurance companies across the United States, they list on there telling them, but specifically most of these are in relation to COVID. They're allowing additional services in relation to COVID, or to allow for the social distancing. So like having the medications be delivered to your home or something like that. Now, you also have to check with your state insurance commission, because remember, some of these are federal things, and of course what's coming out from the White House and the CDC, that's affecting federal. Your state can do the thing itself as well. That's what's great about the United States, is each state can do, if they see a problem, they can take care of it as well. So they might have specific plans in place that are different. So check just pull up Kansas State Insurance Commission or State Insurance Administration, whatever they might call it. And I guarantee it, COVID-19 is going to be the first thing right there on their site. If they don't have a big banner, it's going to be labeled for a link for everything that they have to say about COVID-19 for your state. So as an example, my state's Maryland. They said that the health carriers must waive the cost sharing for any visit where you're diagnosing COVID-19, regardless if it's an ER, the hospital office, drive-through tent, whatever they might be having. The health carriers must waive that cost sharing in my state. So it may be different in other states. The health carriers must waive the lab fees related to COVID-19. They must waive fees associated to, if they come up with a vaccine, then they will waive those fees as well. And we'll go down a little bit more. And they may require, go up just a little bit, I'm sorry. They may require the health carrier to make claims payment for COVID-19 deemed experimental. So if it gets denied saying, oh, no, we're not covering that as experimental, they may make that health payer pay that claim, okay? Now, our governor initiated an emergency regulations, which include the health insurers waive time restrictions on prescription refills, which we already saw a lot of those carriers doing, and they authorize payments to pharmacies for at least a 30-day supply of medication. So in order to help the patients, help with social distancing, help with decreasing the curve of having so many patients with get affected by this virus. Now, Not to say, everybody's like, it's free. Well, look at the insurance carrier. Look at what your state says. It may be different. They are trying to ease the burden on people. We know that during this time, a lot of people are losing their jobs. A lot of people are being displaced. So the state may even be taking measures like they can't kick you out of your homes. They can't do collections during this time. Each state is different, but they may be putting some of those things in effect. So especially when we see a lot of the transportation going down, people aren't able to use the buses or the metro systems as much because they're decreasing those. People can't get to their jobs. They can't get to the doctor. We can see how all of these things are interrelated. So definitely check with your insurance. Everybody hears things on social media. Check what they have to say. Check what the CMS says. Check what CDC says. Check what your state says. Check what Aetna says. It could change. It might change tomorrow. I actually looked them all up today to make sure they still said the same thing. So, definitely look into it. And if you have questions, well, they told me this. What do they say? A lot of people are asking, what modifier do I use? What place of service do I use? It's hard to say because sometimes it depends on the insurance carrier. So go straight to the carrier and see what they say about currently using telemedicine. So it might be different. Somebody might want the GT modifier. Some people say it's not in use anymore. So it just depends. So.
Thank you, Jennifer.
You're welcome.
Do a quick poll here as we finish up. The webinar is now officially over. And we do want to find out if you got value here tonight from CCO's Q&A webinar. And if you did not, please leave us a comment so we can improve it next time. But with so many new people here tonight, I wanted to make sure that we just got your reaction here so we could maybe improve things next time if we need to. Sorry about the delay at the beginning there. That was a new one for me too. So... I've been on a lot of live streams over the last couple days.
I was going to say.
Go ahead.
We were informed too, Boyd, because didn't they say that all of these, just the internet itself is getting a lot of pressure with people staying home and using the internet. So those interwebs are strained.
Thank you.
Wow. Thank you, God.
Thank you. Yes.
96%.
Awesome. Yeah. Please leave us
a comment. And those 3%, not sure. Thank you. Thank you. Let us know how we can improve because, again, we offer these free because we know it's hard to get the content out there that you need. And these are questions that you guys ask. And we do more than one webinar a week, but they are predominantly based on things that you're asking. We've told you guys several times that the CCO club is where it's at to get these questions answered and just be a part of the community. You probably have great information you could impart too. So we want many people there. Now the webinar's over, but if you guys want to stay a little longer, we're going to answer some questions that came through on the chat area and maybe clarify some things for you. Again, you're free to go if you want to, but feel free to stay as we not put us on the spot, but there are some things that we can clarify. And thank you for all your kind words, guys.
The handout is uploaded. I uploaded that a little while ago, so it's in the chat too if you want to take that out. If you're looking for the answer sheets, those are available from the CCO club. We make those available to the members, but basically the chat questions and links to some of the things that we've covered in the webinar are in that handout tonight.
Yeah. Angela made a point. Yeah. Lots of info very fast. And that is because we could talk for a very long time. But we appreciate you guys sticking with us till the end. Again, this is just to whet your appetite, give you some free content that's pertinent, and then jump to the club. So this looks like this is a great Jennifer question. What POS code is used for e-visits and telephone visits?
And the reason I didn't answer it in the chat is because I was researching it and I could not find a very specific answer. Now they are relating these to telemedicine, which is an O2 place of service. I
Mhm.
don't know if all the insurance carriers are, I'm sorry, my nose tickles, if they are going to follow that, or if each carrier may have something different. Now, United Healthcare specifically said O2. So United Healthcare actually follows CMS, so they give pretty clear guidance usually.
Mhm.
But I'm going to stick with the O2. I could not find a definitive answer. I went to numerous sources. I did throw out that HEMA telemedicine toolkit. If you didn't see the link, just Google HEMA telemedicine toolkit, and it brings up this long document, and it has documentation requirements. It has questions, who can provide it, who can do it. It is from 2018. So it is going to be a little bit outdated given our current situation where things are changing based on an emergency status, but it may answer some of the questions you might have. So
Good stuff. What's number 2?
oh,
Boy,
I
it's
actually
working.
saw
If
this.
you,
I'll read it real quick. So can telehealth also
okay.
be a telephone call between the provider and patients and not a video call? And does the provider have to be at the office? So I actually saw somebody's question here and I tried to scroll back up. There's a lot of questions on there and I tried to scroll back up and find it. I did find that yes, that the G, and I forget off the top of my head if it's 012 or G2010 or G2012, I forget. Can be, yes, they did clarify that, CMS, that can be a telephone call. So you can use that Hickspicks code for a telephone call. CMS did say yes. So that can be the telehealth and not a video because you didn't have to have the exchange of images. And then does the provider have to be at the office? I did look at that yesterday. Somebody said, well, if our office is shut down because they're not letting anybody in here, can it do from the provider's house? Well, it did say the originating site is an office, hospital, or other type of facility like nursing home or something, and the patient can be at their home. They did not specifically say the provider can be at home. Now, granted, there might be some special circumstances. I don't know, but CMS did not give a rule about that. We will stick with CMS as office, hospital, or other type of facility as the one site. The patient can be anywhere else. So hopefully that answered it.
Yeah. There's some, I'm looking this side of my.
Yeah. Oh, yeah. No.
Okay. Great question. Just to be clear, so if we are swabbing and sending the sample off to be tested like to LabCorp, which is a huge, we just bill the 99000. But if we are doing the test in-house, we bill 99000 and U0002. Okay, I saw this pop up a lot. So I wanted to let you know that this is the Hickspicks code, right? And think of it just like if you are doing HIV testing. Okay, you're going to do it the same way. So yes, 99000 is the CPT code, and U0002 is the code, the Hickspicks code that is used. Now, if you don't use a Hickspicks code, you don't need it, right? So how do you do it when you code for HIV? The lab test for HIV or other types of labs that are sending out. They're just stating that the Hickspicks code to identify the, which, gosh, let me look over here. So another example, because I got my cheat sheet over here. Let's see. No, that's for the drug and the stick. I guess I don't have a cheat sheet on there because that was for the Z2-3 for the flu, and then you've got 90662 and G0008. Same example, how you would do that, right? But U0002 was the created code by WHO and the CDC for the Hickspicks. So Hope that clarifies for you. So it's nothing new that we're not doing already. It's just saying, hey, by the way, that's the Hickspicks code we use. The CBT code is 99000. Let's see, next one. If a patient has a scheduled appointment and the provider calls the patient, would it be considered patient initiated because it was already scheduled? Well, if it's already scheduled, then you're okay, right? And yes, the answer to that is yes, right? So is
Patient
that right, Jennifer,
initiated.
or is there an example?
Patient initiated, so the patient scheduled for appointment and provider calls the patient. No, the patient has to initiate the phone call, not just if they were, so if they were scheduled and you want to make them a telehealth instead of them coming into the office would need to notify them. You may not want to come in the office. You may want to use telehealth services. And then if the patient calls back and says, yes, I want to do this, you say, I have your consent to do telehealth services. Okay. But it is patient initiated. They generate the phone call. They call with the question. They call to say, I'm not feeling well. What do you think?
Right.
Should I come in? Should I, yeah.
So you need to document all that too, right? So
Yeah,
think of it as the auditor saying, okay, no, you need to document that the patient called back and said, I think I shouldn't come in.
The consent, the place of service, where the patient is. And there was one other thing, somebody brought it up and I confirmed it in that toolkit from AHIMA, that there is, that there are certain documentation requirements that must be put in the record in order to bill for a telehealth. So definitely
So you need to be having meetings right now with your office and letting them know, hey, this documentation has to be in place for it to work. In the hospital or outpatient, can a provider reference another provider's examination findings on the same date of service, or even defer the exam and documentation the reason when dealing with patients infected with coronavirus and receive credit for the exam, and add the CR modifier to the E&M? Okay. I can answer one portion of this, but this is Jennifer's forte too.
Go ahead.
The first part is yes. In fact, I just watched a webinar in this. If you, she called it drive-by consult. Drive-by, talking. And so she said, you're in the hospital, and when you follow the provider and you're watching them do this, they said they walk out of one room and they pass another provider and they're to say, hey, are you getting ready to go see room 203? Yes. I just looked at their labs, blah, 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 blah. And they're discussing this stuff. Okay. Because it's another, but they don't add that discussion, but they use that information that they discussed in the hall with that other provider to do their plan of care, right? That needs to be documented that they did that. It's just not, and they forget to do that. So yes, if the providers talk to each other and stuff, that portion is yes. It just has to be documented that yes, they spoke with and they referred, his understanding of the labs or her yes, that can be documented. Drive-by. It's not an official constant, but they discussed it. It's just like picking up a book and looking up the signs and symptoms for something odd. Now, the second portion on the CR modifier to the E&M, I can't answer that. Jennifer will know the answer to that.
I'm trying to look up the CR modifier and it's making me jump through all these hoops. The CR modifier is to be used in times of an emergency, a catastrophe or disaster. So that modifier needs to be only when the service or an item is impacted by an emergency. Let me see here if I can see a little bit more about this. I've never had to use the CR modifier, so I need to find out about it. It's used in relation to Medicare Part B items and services for institutional, non-institutional. It's no longer, I'm trying to see if it could be used on an E&M.
While she's looking at that,
yeah.
I would
Yeah,
just
it's
say
appended to
pandemic is
Hickspicks
not
Codes,
considered an
so
emergency. So,
yeah.
that this is if a tornado comes through,
I mean,
or
their reference is like Katrina. So
yeah.
services or HICPIC codes during the use of that emergency that we had of Katrina for a disaster. Since this is technically a nationwide emergency, I don't know if that would even be required. And unfortunately, this is kind of new territory for us. We haven't
That's right.
come across
So
anything
you know
like
what's
this
going to
before.
happen
So
when you guys get the guidelines for 2021, I guarantee pandemic is going to be on there. Yeah, they will initiate
Probably
the
change
stuff
it.
because you notice all the changes that happened for 2020. A lot of that stuff was, terrorism related, and who was involved in the shooting, where they, stuff like that. So
yeah,
we get codes for statistics that we need to capture, and pandemic will be in the 2021. Mark my words. So, okay, we're ready for the next one. What about 6-month checkup for chronic illness? May we use telehealth services?
That's what I was kind of suggesting to my providers is, those people who are 3-month, 4-month, 6-month, either are they well enough to push them off another month or two, say, okay, let's have you come in. I mean, a 6-month checkup. My only thought today that I had is, okay, because our providers were surgeons, so because our providers cannot perform elective surgeries anymore, only emergency surgeries can be performed, they now have 2 days a week where they're not working. So why can't they come in the office and review some of these people for telehealth? Now, apparently they are establishing a telehealth equipped, or they want to make sure they're doing it right. So they're getting telehealth initiated properly. So, would they be able to do one of these 6-month people so they don't have to come in, or is it something that they could push them off for another month or two? It would have to kind of depend upon the person's condition, for one, and what you think, their age. Like, we notified all people over a certain age, you may not want to come in the office. You may want to cancel your appointment and extend it out a couple months or something like that. Notify them ahead of time first. So I think it would depend on the situation of the patient, and possibly they don't have transportation right now, or things like that, so they wouldn't be able to come in anyways. So if that's the case and they need to be seen because they need medication refills and make sure that they're checking up on them and make sure that they are healthy right now, then I can see using telehealth. But if it's in our case a hip replacement 6 months down the line, that can wait another month. That's okay. You don't have to follow up with them today, so via telehealth. But
Any more, Boyd?
Nope, that's it.
Hey, all right. There's a lot of other stuff that came out, and so again, just you guys put them, send it to the club, and we'll be able to follow up. This is something we're going to be talking about for a while. In the meantime, we are on YouTube. Probably one of the most popular ways to find CCO. We hear people say they found us on YouTube. So it's medical coding search. Make sure you click the little bell when you subscribe as well, and then you'll know every time we go live. Boyd does a great job that we live stream on YouTube, Facebook, and LinkedIn. But honestly, I've checked each of those, and YouTube tends to stream the most clear and fastest. So that's where I would go to. Also, hey, there's almost 1,500 videos up there. All you have to do is go to the little looking glass, put in a information, and it'll pop up a dozen videos.
Put in remote. Some people said, okay, well, now I'm remote. You guys should do a video on remote. We actually have one. So go ahead and search for it, and you will see some of the tips that Alicia put out there for working remotely. So.
There's videos that are even 8 years old on there. So don't forget to like and like us on Facebook, and that's really easy to find, cco.us. Lori gets some really cool stuff that she puts up, like word of the day or something. We also do presentations to chapters now that virtual, and I suspect we're going to get some more approval from the AAPC and AHIMA. Their CEUs go together now. So these are some topics that we've got pre-recorded that you could have just, register, and Lori will get you set up for doing a presentation that has already been done. So you don't need to have us there to do that. And let us know if you got topics you want us to do. So we won't be traveling doing live presentations for a while.
But we can virtual.
That's
Sweet.
right.
So
Yeah.
yes.
And if something specific you need from us, let us know. There's a survey. Please come to the survey. But again, we keep saying cco.us club. That's where it's happening. We want to see you there. Share with your friends that this was helpful, and let us know this club's out there. And you can network with each other there too. So Facebook, YouTube, LinkedIn. Here's all of our social media and other links that are helpful. Yeah. Now you can see my hair's darker.
It is. It's a fact.
Boyd's still bald though, guys.
That's
Everybody,
right.
I tell you women are pretty fond of Boyd's bald head. I tell you, we get lots of comments on it.
I got pretty eyes from my wife tonight, so I'll take that. I'll take that wherever I can get it.
Yeah.
Well, thank you everybody for being with us, especially those first timers that are out there. We very much welcome you to our tribe, as you say. We're going to be trying to do some more lives, I think, probably over the next couple of weeks to try to, make sure that you feel like you're part of the community. So probably start looking next week back to schedules on YouTube and Facebook for our live streams as well. Any other closing thoughts here as let's say goodbye tonight?
No, let us know if there's something you need help with coding, and we'll get it out there and do a video on it.
Mm-hmm.
We can break some of these
your
other
hands.
topics and unpack them a little bit. Don't touch your face. Think of the Death Star. Eyes, nose, mouth. I can still see Luke Skywalker and that little that bomb going in and sucking down the hole, and boom, then you got a germ.
There you go. Yeah,
Bye, guys.
that was an interesting one. All right. Good night, everybody.
Bye.